The topic of our event today is Patient Navigation, a guide for DLBCL and follicular lymphoma patients. Here's the agenda for today. I'll introduce our speaker, Dr. Electra Paskett. Dr. Paskett will then spend the next 30 minutes or so giving us her presentation. After the presentation, we'll open it up for your questions and comments. Let me take a minute to introduce our speaker. Dr. Electra Paskett became the Marion N. Rowley Professor of Cancer Research at The Ohio State University in 2002. She is a distinguished professor and director of the Division of Cancer Prevention and Control in the College of Medicine, professor in the Division of Epidemiology in the College of Public Health, deputy director for Population Sciences and Community Outreach in the OSU Comprehensive Cancer Center, and founding director of the Center for Cancer Health Equity at the James Cancer Hospital. Dr. Paskett's over 500 peer-reviewed publications showcase her work in interventions research directed at cancer prevention, early detection, and survivorship issues. So with that, I'm going to turn it over to Dr. Paskett.
Hello, everybody. Thank you so much for inviting me to speak with you today. I'm going to share my screen and then we will start. Okay, so appreciate the introduction, appreciate everybody's time today. What I'm going to talk about is patient navigation. Now, most of the examples I'm going to give you are not focused in lymphoma. They're focused in other types of cancer, but everything that I'm saying can apply to any cancer, whether it's lymphoma, leukemia, pancreatic cancer, or the examples that I'll give you today focus on breast, cervical, colon. And then you'll see when I talk about what we're doing here at Ohio State, we just instituted a patient navigator in the HEMONC clinic. So we are moving forward specifically in that clinic. And again, everything that I'm telling you about patient navigation applies to whatever cancer a person has or can be used in any cancer setting. So I'm going to start with a case presentation. These are true people and their situations. Their names have been changed. So the first case here, Mrs. Jones is a 33-year-old Black woman with a cervical abnormality on routine Pap test. Her OBGYN recommended a colposcopy, which is a diagnostic follow-up, within 6 weeks. She has no other health issues. She has 5-year-old twins. She's college educated and working. Mr. Smith is a 51-year-old Black man. He presented with rectal bleeding and pain to his primary care provider, who recommended that Mr. Smith get a colonoscopy as soon as possible. Mr. Smith has a history of mental health issues. He has no transportation himself, and he has difficulty understanding instructions, and he lives at home. So the question I want you to think about is who followed up with their doctor's recommendation for follow-up of their abnormal tests. And we'll get back to Mrs. Jones and Mr. Smith at the end of the presentation, but I want you to think about that. So there are barriers to care that people have that have an impact. And these are some of the barriers that we know patients face. Financial or health insurance, transportation, basic needs become barriers to healthcare, food, shelter, utilities, language, whether it's health literacy, or that patients don't speak English. Lack of knowledge, different cultures, and fear of cancer. The health system itself is a barrier to receiving care, as are the prevalence of comorbidities or comorbid conditions. And what's the impact of these barriers? How do these barriers then cause problems? Well, they cause cancellations and no-shows, which causes failure to receive treatment, which causes non-adherence. And it's also non-adherence to preventive health behaviors like getting screening or stop smoking. And all of these can contribute to poor outcomes, which means later stage at diagnosis and death. Now, When you think of the healthcare system, to many of us, it seems like a maze, and we need our own personal GPS to navigate the healthcare system, and especially vulnerable populations. They need some help. And these are just, again, the barriers that we talked about all around this maze that we enter. And some of, the communication with medical personnel, sometimes that's also a barrier. How to even get to the facility is a problem, and scheduling. And these are even, more compounded if people are vulnerable, and they don't have systems that can help them. So one of the solutions is patient navigation, and I like to refer to that as a personalized GPS. Patient Navigator can translate medical jargon to what to do in lay language. They can provide understanding of the healthcare system pathways. They can facilitate accrual to clinical trials. They can provide coaching and cultural, emotional, and psychosocial support. They can provide assistance with physical needs and other barriers to care. And they mostly do this by facilitating referrals to community resources and social services. So what's patient navigation? I'm now going to talk a little bit about the birth of patient navigation. That was the brainchild of Dr. Harold Freeman, who we call the father of patient navigation. Though in 1990 in Harlem, New York, Dr. Freeman noted that in the 22-year period preceding that date, among the lowest income Black women, only 6% were diagnosed with their breast cancer at stage 1. And the 5-year survival rate in that population was only 39%. The commonly experienced barriers to getting timely care were financial, such as no health insurance, communication and information barriers, fear, distrust, and emotional barriers. So they instituted an intervention that consisted of 2 elements. They provided free or low-cost examinations of mammograms according to guidelines, and then they provided patient navigation to ensure that all patients received a timely diagnosis and then treatment. After implementation of this, instead of 6% at early stage, 41% were diagnosed at early stage, and the 5-year survival rate went from 39% to 70%. Now, Dr. Freeman and his team developed principles of navigation, which are listed here. Basically, they're patient-centric. Navigators work for the patient. They do not work for the doctor. Integrated into the healthcare system. The core function of a navigator is to identify and then eliminate the barriers that each individual patient has to receiving timely care. Patient navigation should be defined with a clear scope of practice. It should be cost effective. You should determine who should do the navigation based on what level of care or step the patient is in, and there needs to be coordination. Very simple, simply stated principles of navigation. So, what we like to think of patient navigation is that this first yellow bar here is when the patient hits the door of the clinic. That's how I like to sort of describe patient navigation. But in the initial market model in Harlem, the patient navigators went out to the community to get women to get screened, and then any abnormal finding, the women were navigated from abnormal results through diagnosis and treatment in through the survivorship program. And again, this type of a program can be instituted for whatever cancer in whatever location. So the underlying premise of patient navigation is that with patient navigation, the patients will get into the health system at all and get in faster. Abnormalities will be resolved, or cancers will be detected and treated earlier, resulting in better outcomes in terms of morbidity and mortality, quality of care, satisfaction, and costs. So now I want to talk a little bit about the study that validated patient navigation, proved that it worked, proved that it was effective, and it is called the Patient Navigation Research Program, and we were one of the sites that did this. So this is familiar to you now. I showed this to you a couple of slides ago, but the general framework of patient navigation for Patient Navigation Research Program, which I will refer to as PNRP, was at the time of the abnormal finding diagnosis and then followed patients to resolution. So here we have at the bottom abnormal results, diagnosis, and treatment. So the goal was to eliminate the critical delivery gap for populations experiencing disparities. Usually populations experiencing disparities will drop out between the abnormal results and diagnosis. There's a drop point there. People are lost. And between diagnosis and treatment, there's a drop-off point where people don't follow up, and thus they are lost and have poor outcomes. So in PNRP, the navigators worked with cancer patients to navigate the healthcare system and access appropriate social and financial services. The most important role of the navigators was to ensure that individuals with suspicious cancer finding receive timely diagnosis and treatment. And I'm going to come back and show you some data exactly on that in just a few minutes. So just skim these next couple of slides. I wanted to show you the different sites that participated. So we had Northwestern in Chicago, University of Texas, San Antonio, University of Rochester in New York State, Boston University, Massachusetts, Ohio State University here, George Washington University in DC, Denver in Denver, Colorado, Moffitt Cancer Center in Tampa, and the Northwest Portland Area Indian Health Board in Portland, Oregon. And then so those were the physical locations, and these were the 4 types of cancer or abnormalities that were eligible to participate in this study. So we had breast, cervical, colorectal, and prostate. You can see everybody did breast. You had the choice to do 1, 2, 3, or all 4 of these cancers, and you can see how that was distributed. And then within each site, there were different populations based on their catchment area where they were, that these sites could focus on and enroll. So we had a mix of African American, Hispanic, other racial and ethnic minorities, and underserved or low income populations that were included in the study. So what we focused on in patient navigation research program, our hypothesis was that navigated patients would receive timelier, definitive resolution following abnormal findings, and receive timelier treatments following a diagnosis, and thus improve their satisfaction with the healthcare experience. We also looked at the impact on diagnostic resolution as kind of our main outcome that I'm going to show you today. And that was, here are some of our the areas we looked at. Navigation might decrease the time. So we looked at time to diagnostic resolution. We looked at the impact of navigation if you had more barriers, and then kind of strategizing that if you had more barriers, it'd be more effective to have in-person navigation versus a telephone navigation. So these are the results of the study, and you don't have to look at all the numbers or everything. I'll just tell you that we divided it by type of cancer and by the A, the B, the C. Those are represent the clinical locations. But I want to draw your attention down here to kind of the, what is this on a triangle, but this bottom figure that's open at the bottom, this is the overall impact of navigation. And anything that is over 1 favors navigation. So overwhelmingly, there was a 50% increase in coming in and getting your abnormality resolved for those patients that were in the navigation arm. And this is just one type of analysis that we did. We looked at, again, the impact of navigation on how long it took women to get in. This is for being resolved with their abnormality for breast cancer patients by insurance. So the red line is the uninsured, the dotted yellow is public, and the top one is private. So the non-navigated is the first clustering of the lines on the left part, and you can see the number of days to diagnostic resolution virtually for all three groups by insurance status was between 60 and 70%. But then if you go over here to right under the navigated group, what did we see? Actually, the uninsured benefited the most from navigation. That was down to about 40 days, and then public was about 47, and private insurance was 65. So the navigator really had the biggest impact in the uninsured group. This is our results just at our site. And this is looking at days since the people enrolled in the study and the probability of not coming in. So at the beginning, you can see the lines kind of overlap where red is control and blue is getting the navigation. But about 200, a little over 200 days, the lines started splitting so that the people who had received the navigation in the blue bar, almost everybody had been resolved, whereas not everybody in the control group had been resolved. And again, we estimated that the intervention became significant right about 6 months. So basically, navigation was finding people who would have been lost. So basically, you know, the finding was that navigation reduced the time to diagnostic resolution. And there was a suggestion actually across all the sites, not just our site, that the benefits of navigation occur late. So if you're going to go in and get followed up, you're going to go in no matter what. But it's the stragglers that navigation really helps. And we estimated that through patient navigation, 18 to 25% of those people who would have been lost, never gone in to get their abnormality followed up, would have been lost. So that's 18 to 20%, sorry, of people who might have had their cancer diagnosed later. We were able to get them in to be treated. So we were asking then a question, well, are there a subset of patients who really benefit from navigation? Now, if we could find out beforehand, maybe we could, you know, direct our resources in navigation to those people. So we did a series of analyses, and I'm going to tell you to read the top, because that is the punchline here. That navigation eliminated any disparities in coming in to get followed up by income, so that we eliminated the fact that those of lower income were less likely to get followed up. We eliminated disparities by employments. In the control arm, those who were unemployed were less likely to come in. We eliminated that disparity. We eliminated the disparity by housing, so that if people weren't homeowners, you know, if they rented or others, they were less likely to come in the control arm. We eliminated that disparity in the navigation arm. Here's a look at if people, you know, have comorbid conditions, other health conditions. I put that up at the first as one of the barriers that people have to coming in. And again, here you can see that the bottom line is control, and this other line is navigated. And we show that in people who have 2+ major comorbidities, navigation was able to get them in. They were resolving faster than the controls. Again, later on is sort of where navigation kicks in for those who really wouldn't have come in unless they had navigation. This one is, does the type of barrier that a person have matter? And we showed yes. So this is within those who, this is irrespective of navigation, but those who have social barriers, they are easier to resolve. I'm sorry, harder to resolve than those who have no barriers. So the top line is those with no barriers here. These are other barriers and social barriers. So social barriers were really hard to resolve and to get people in. And then we did another analysis where we were trying to identify patients who were most likely to have barriers. And if they have barriers to care, because we know the more barriers they have, the less likely they're going to come in on time. And then depending on type of barrier, the harder it is to get them in. And we looked at our data and actually found that patients who were non-white, lower educated, unemployed or retired, income less than 50,000, uninsured, and have comorbidities were more likely to report a barrier to care. And then those are the people that really need help in getting into the health system soon. The last thing that we looked at is, does navigation, having a navigator, improve the quality of care that you receive? And we have one hint here, and that is that women who received a navigator were more likely to go on hormone therapy that was prescribed by their doctor versus the women who didn't have a navigator. We didn't have any effect here in getting post-lumpectomy radiation therapy, but we did have an effect on being on hormone therapy. So in summary, what I've tried to show you is that patient navigation results in reduction in delays in care, reduction in number of patients who never complete needed care, or the proportion who are lost to the healthcare system, and that navigation is most effective where the gaps and the needs are the greatest, or where people would have fallen. That's where we caught them, is at the point where they would have fallen. So I want to now in this half of the presentation talk a little bit about what we're doing in here at Ohio State to show you how we have taken what we learned in patient navigation and research program and instituted it in clinical care. So we call our navigation program Wayfinder, and we've focused on our underserved and vulnerable populations, which are racial and ethnic minorities, Medicare, Medicaid, rural Appalachian, both at our Wexner Medical Center and also our James Cancer Hospital clinics. And these are our wonderful navigators here. So again, to review what I said, we know navigation works. And currently, there are some laws in place. The CMS rule now will cover patient navigation, but a lot of places are now exploring ways that we can implement this CMS reimbursement. It's not, easy. You got to work out a lot of things. And we implement patient navigation remotely through telephone in the clinic. And then we also focus across the cancer continuum and from the community to the clinic. So the cancer continuum means from healthy people all the way through till survivorship. So we call our navigation Wayfinder, as I said, but Wayfinder does what's called continuum of care patient navigation from the community to the clinic. So in the community, we talk about prevention, education, risk factors, the need for screening. And if folks have an abnormal screen, we make sure to get them in for diagnosis. If they've been diagnosed with a cancer, get them in to start their treatment. And we are with them throughout treatment into survivorship or palliative care. So we work with our community health workers. I have community health workers in each of our different communities. And then we have the patient navigators who are in the clinic. Our community health workers are now trained on navigation principles, and they can navigate community members to get cancer screening. It's a seamless partnership. It's culturally competent. I have 6 bilingual staff, or I should say we speak 6 languages in our group. And my community health workers are members of the communities that we work with. They make sure the handoff or the transitions from the abnormal screen to diagnosis, or the diagnosis to starting the treatment happens, that the transition happens, people don't get lost. They address barriers, ensure ensure adherence, maximize communication, and then they work within a network. So this is just a little description of my navigators. A navigator is a description, is described as an individual who does not carry a clinical license and does not have clinical responsibilities. Those are my navigators. We don't have nurse navigators, we just have patient navigators. This ensures their ability to focus on non-clinical barriers to care, which include communication, informational, medical system, financial, practical, social, emotional, those that we talked about at the beginning. We provide additional training to ensure their confidence, to address identified barriers to care and link patients to reliable sources. They go through the core competencies for non-clinically licensed patient navigators, and that were developed along with a certification program from the Academy of Oncology Nurse and Patient Navigators. And I can just tell you that our patients not only express satisfaction with the navigator, but also with the ability to understand the information that the navigators share. Now, the other part is our community health workers. They're, as I said, members of the community, the public health sector, who have an understanding of the culture of the community they represent. And that enables them to serve as a liaison between the healthcare team and the community to, again, ensure that seamless care. There is a certification for this position that goes through the Board of Nursing here in Ohio. And the community health workers and health system embedded patient navigators, as I said, work together to address disparities and improve cancer outcomes through education, ensuring the smooth transition through the healthcare system, linking to available resources both here and in the community, and providing emotional support and addressing financial barriers. And again, this is just the continuum. These are some of the things the community health worker does: outreach and education, linked to screening, community resources. And then they work with the navigator if needed to provide transportation assistance, link with insurance. And then if needed, if there's a diagnosis then or an abnormal finding, that they link with a patient navigator who can help facilitate the diagnostic testing, address barriers to care, and a link to a whole host of resources. But the whole goal here is to provide this seamless transition through care pathway. So I'm going to just tell you about some past and future studies that we've done and initiatives. So we've done a lot with breast. Of course, these were funded through Komen. So we did some community outreach mammography. This is one of our mammogram vans. We now have 2 of them. And we have a freestanding breast center that we work with. They're a great partner. We've worked closely with the Ohio Department of Health. They actually gave us a small grant to help enroll more women onto the breast and cervical cancer detection program and to get increased age-appropriate screening. And this initiative really focused on the counties that have no mammogram facilities that are here in these dark colors. So those are the counties that we really focused on taking our mobile van to. And you can see from 2015 till last year, we facilitated over 6,000 mammograms with 80 cancers detected, all that use that continuum of care navigation. I mentioned that the Ohio Department of Health asked us to help increase enrollment onto the breast and cervical cancer detection program. We increased enrollment by 51% in 1 year. And then we've hosted, just in 2023 alone, we hosted 57 mobile events in urban settings for our mammogram van and 15 in southeastern Ohio. There, just again this year, 1,100 women reached, and then we navigated 78 women to diagnostic resolution, and we also enrolled 763 of those women in the breast and cervical cancer early detection program to pay for their service, and similar for cervical services, etc. We got another small grant called the upper payment limit, which was really to focus in the breast center and reducing the time to diagnosis and start of treatment. And second, in the family medicine clinic, which has a high proportion of Medicaid patients, which had high cancellation and no-show rates. And then we got a small grant from the One Family Foundation to provide financial assistance to any cancer patient. This is just some data showing you how we increased the proportion of women that were diagnosed with, time from diagnosis, from abnormal to diagnosis. We really increased it up to 95% within 30 days. And then just to show a little bit about our return on investment, also, I mentioned that we are focusing on reducing no-show and cancellation rates. Well, we got it down to 14%. Well, it was baseline 14%. We got it down to 5%. So from 14 to 5, really down to a third. And then for those people, we navigated them to get mammograms, pap smears, and colon screening tests if they needed them. And you can see the adherence, 93, 96, and 95% respectively. And what was our return on investment? Is 2 to 2.6 fold return on investment by, not having canceled or no-show appointments, for example. In the financial navigation portion, you can see that we navigated almost 1,000 patients with almost 900 receiving some sort of financial assistance, with the most being groceries, gas, utilities, etc. So currently, now or today, we are still in that family medicine clinic. We are in the colposcopy clinic where women with abnormal pap tests need to come in. The no-show rate there was 50%. And in the GI clinic where the no-show rate for a colonoscopy was 30%. We're also in the cancer clinics. We have a navigator in breast center. That's Sherry with navigator in thoracic oncology. Rebecca, our brand new navigator in hematology oncology, and navigator in GYN oncology, focusing on clinical trial accrual. And I just lastly really want to talk a little bit about our education. We translate materials, distribute these translated materials throughout the community, and we provide community education. And especially during COVID, we really pitched in and focused on, on our underserved communities. And we just didn't focus on cancer. We really went out. We also conducted screenings, mobile vans, and connected people to community resources, including internet resources, tutoring, food pantries, and domestic follow-up. All right, as we're ending here, let's get back to my case presentation. We had Mrs. Jones, who had an abnormal pap. She needed a colposcopy, and Mr. Smith, who had rectal bleeding, and he needed a colonoscopy. So the question is, who returned for follow-up? And when I give this case study usually to medical students, at the beginning, most of them say, oh, it was Mrs. Jones. They raise their hand. Then when I get to the end, they really don't know. A few more for Mr. Smith, but they really don't know. And the answer is Mr. Smith. Mr. Smith, that wasn't his name, but he is a real patient that was in patient navigation research program here. And he, after 3 tries, he went in and got his colonoscopy. The navigator coached him to do the prep, that lovely prep as instructed. He went to she actually took him to the hospital because he had no transportation, and brought him home. She facilitated the phone calls to his doctor's office for scheduling and transportation. I believe they had to reschedule 3 times. And a 5-centimeter polyp was removed on the colonoscopy, which means we prevented a cancer in this gentleman. And then he was coached and encouraged to become his own navigator. So, in conclusion, barriers impact access and adherence to cancer care for many populations for any cancer. Patient navigation has been evaluated and demonstrated to improve cancer care, especially in minority and vulnerable populations. Navigation is viable telephone, in person, and with community health workers as community connectors to the patient navigators. Patient navigation needs to be implemented in routine care and in survivorship care with a focus on disparity populations. Payment models need to be explored, including how we can really implement the CMS rule. It can be implemented along the cancer continuum. We don't know as much about it in survivorship care, but it can be utilized there. Patient navigation mainly assesses and then addresses the individual barriers a patient has, including related to the social determinants of health, of housing, food, utilities, transportation, violence, etc. Patient navigation can reduce cancellations and no-shows, as well as address issues patients have and facilitate the receipt of additional testing and visits. And patient navigators can help get patients back in for needed tests and visits. We also have demonstrated that patient navigation has a positive return on investment, and patients have high satisfaction with patient navigation and overall care. So I ask, can everyone have a patient navigator? Because we all have different barriers. So this is our team and our Center for Cancer Health Equity. And I thank you so much for your attention. And I'm happy to take questions.
Thank you so much for your very informative presentation today, Dr. Paskett. That's amazing to hear about the work that's being done in patient navigation. So I believe Dan raised his hand. Dan, do you have a question? If not, no worries. Okay, so as we wait for questions to come in, we did have a few pre-submitted patient questions, Dr. Paskett, that I'll go ahead and just ask you. So one of them was, do you know if most hospitals have patient navigators? If my hospital doesn't have a patient navigator, could I call a facility that does to help me with resources in my area?
Excellent question. And I can't answer in terms of, does your hospital have a navigator? Not every hospital has a navigator, unfortunately, because until January, there really wasn't a way to get reimbursed for navigation. There usually are people who serve as navigators, but might not necessarily be a patient navigator. So I think you could ask if your facility has a navigator. You certainly could encourage them to get a patient navigator now that there is the CMS rule in place to you need to comply to certain steps in order to then have that be a billable service. But as I showed you, you know, the business case for this is that it pays for itself twofold. So like if you invest in, I'm not going to say it costs 100,000. I'm just going to do round numbers. If an institution will invest in the salary and benefits of a patient navigator, space, et cetera, 100,000, let's say, you know, they will get 100,000, at least 100,000 over over that. So they'll get 200,000 back, cover the 1,000 they invested, and you know, can they use it to hire another patient navigator? That's what our data says. And how do we calculate that? Well, we knew what the no-show rates were, and if you know you have a 30% no-show rate in a colonoscopy, and you know you can't call that morning and say, oh, Mrs. Smith, can you come in for a colonoscopy? No, you can't, because you have to prep for those lovely colonoscopies. So you've lost that revenue, but you've still paid for the nurses to be there, the room, and all that. So you've lost all that revenue. And so what a patient navigator can do is keep you from losing that revenue. And that's just the cost right there. It doesn't even count downstream resources, et cetera. But patient navigation pays for itself in addition to then CMS reimbursement. And it's the right thing to do. It's the right thing to do.
That's good to know. Thank you so much for answering that. Another patient is wanting to know, what is the training process to become a patient navigator? And some of these you may have already answered in your presentation, where these were pre-submitted. If you could summarize generally here as well, that would be great.
Right. So when we hire our patient navigators, again, I told you they're not nurse navigators. There are places that hire nurse navigators. So I'm not going to speak on nurse navigators. I'm just going to talk about our patient navigators, non-clinical patient navigators who we hire. So we have them all take the certification program from the Academy of Nurse and Patient Navigators, or there's also a course at George Washington University that certifies them, and then we provide additional training to them for over here for patient navigation, and then they get specific training for whatever clinic they're going to be working in. You know, the breast is different than our HEMONC navigator gets, is different from our GYN-ONC. So they get specific training. But the basic training is, you know, on how do you assess individual barriers to care. There's a checklist, a barriers checklist. And then how do you create your referral system to then refer a patient? If a patient needs transportation, how do you know where to refer them to for help? If they need, you know, a translator, what do you do? If they can't pay, what do you do? So, you know, you learn all this stuff. And then we do have them shadow one of our navigators to kind of get the hang of how you talk to the patients, how you do your, we use a system to chart everything, the barriers that were recorded. What was the referral that was made? Was that barrier resolved? And also, of course, did the patient come in and things like that. So a lot of training goes into that. And we usually look for people who have had some type of past experience, job experience, either with social work or in a medical office or something like that, that we use for past experience.
That's good to know about the training process. Thank you so much for answering that. One question that I have, I think that other patients might also potentially want to know is, so you stated that, so there's the cost, right, from the facility to hire the patient navigator. The patients themselves who are being helped by the patient navigator, is that a cost for them to receive that support?
That's a really good question, because right now we don't charge the patients. But if we do, if we all, all institutions figure out how to do the CMS reimbursement, is there going to be a cost to the patient? You know, a copay for a patient navigator. We're not sure how much that will be. This is all new territory, brand new territory. The rule was just approved in January, and you know, I'm on the National American Cancer Society National Navigation Roundtable, and we have, you know, a little subgroup that works on this, and we're looking at this all over. We're seeing if there's test cases so we can see what has happened. But you know, if there's going to be a copay to the patient because their insurance was billed, we need to know what that's going to be so that we can inform the patient up front. And so I always say, hey, you know, what happens if, you know, you tell a patient, okay, yeah, you can have this patient navigator help you, but you're going to get a $20 bill for a patient navigator from your insurance, you know, because it's your copay. Patient, you know, the patient say, no, I don't want that. Uh, what's that going to do to patient navigation? I don't know. So, anyway, this is all new. We're like into space here now. We have no unexplored space. We don't know. And that's why we're not moving forward yet, because we don't know what all the dotting the I's, crossing the T's is, including that. And so we're not doing, I know a lot of places are not doing it. And that's one of the big reasons right now, is we don't feel comfortable with that.
That makes total sense. Thank you for answering that question. That's very insightful. All right, we have two more pre-submitted questions that we'll look to get through, and then anyone else that attended today, if you have anything you want to put in the chat, feel free to do so. All right, so this patient is wondering, can patient navigators connect me to mental health specialists for follicular lymphoma?
Molecular mental health experts for follicular lymphoma.
Yes, so mental health experts that have specialty in, or would that be another title, like another individual at the hospital that they could contact to see?
Well, what patient navigators will do, they'll have a resource list of medical health experts that have experience in treating patients with follicular lymphoma. I think that's what you mean. And yes, they could put together a list like that and then provide a name for a person. They could facilitate, this is the number you need to call. And if there's issues with scheduling, they can help with that.
That's good to know. Okay. And then the last question here that we have is, and I believe you previously already answered this, but thank you for thank you for summarizing again here. So can a patient navigator help me find financial resources for my DLBCL treatment?
Yeah, again, patient navigators will put together their list of resources. So if you have trouble paying for your treatments, don't know where, they'll have a resource list, which might start with the financial counselor at your institution, your treatment facility. Mostly every treatment facility has a financial counselor that can help you, and they can lead you to that person. They can also be like an advocate with you to help translate the jargon that is used that you don't understand. So yes, patient navigators can help you find a way to pay for your treatment.
That's great news. And it's wonderful to hear about the amazing things that Ohio State University Cancer Center is doing and your team, Dr. Paskett. And we're very grateful for your presentation and for taking the time to support our patient community. So we'll go ahead and wrap up here. Let me go ahead. I do want to just share a free resource, let patients know about. So one of the things that we offer here at HealthTree is called Cure Hub, HealthTree Cure Hub. You can become a Cure contributor and access cancer research by participating in surveys, find clinical trials, locate side effects, solutions, and you can access your free HealthTree Cure Hub by visiting the link at the bottom of this slide. You can select your disease type, such as diffuse large B-cell lymphoma or follicular lymphoma within Cure Hub itself. So the link here is healthtree.org/bloodcancer/Cure Hub. And again, if based on which type of lymphoma you have, you can select it within the platform itself. I'd also like to mention when our next webinar will take place for our DLBCL community. On July 23rd, we'll hear from Dr. Pallavi Torka, who will share insight about rituximab and polatuzumab's role in DLBCL. More events for our DLBCL and follicular lymphomas communities will be posted in the upcoming weeks. To register for this event, please visit the link at the bottom of this slide. We'll also send the link to the event page in our follow-up email. I want to again take a moment to thank our HealthTree community for DLBCL and follicular lymphoma sponsors, without whom this event would not be possible, Regeneron and Bristol Myers Squibb. Thank you everyone for helping us build a strong HealthTree community. I appreciate you all, and I hope to see each of you again soon. Please don't hesitate to reach out to this email if you have any questions about HealthTree or upcoming events. Thank you so much.